Hi, everyone. My name is Jeff Frankel, and I am the managing editor of JEMS. Welcome to today's webcast, Worth the Wait, the Importance of Weight Accuracy and Medication Dosing in EMS. Thank you to Hinckley Medical for sponsoring today's presentation. Just a few housekeeping notes before we get started. We are both live and interactive today, and you could ask a question at any time by clicking in the Q&A box below. We'll be answering your questions at the end of today's event. So no worries if you ask a question, we don't get to a while. You could also enter any technical support questions in that Q&A box, and a member of our team will be able to assist you there. If you're running any pop-up blocking software, you'll need to disable it to view this webcast. We also recommend that you close all the browsers or applications for a better performance of your PC or Mac. This webcast will be available on demand within 24 hours, and a reminder email will be sent out to everyone as well. You also find it at gems.com/webcasts. Now, I want to pass it off to one of our speakers today, Dr. Abraham Campos. Dr. Campos, take it away.
Thank you, Jeff. Thanks for that intro. Like I said, presentation we're talking today is going to be about weight and dosing. Kind of in the title, the importance of weight accuracy and medication dosing EMS. Lucky enough to have a close friend and someone I've worked with in the past on a professional level, not directly, but Mark McCullough as well. So just a quick background and intro. So about myself, I'm it's always good to know who's talking to you. So I'm dual board certified in emergency medicine EMS, completed my training at University of Nebraska Medical Center, followed up by an EMS fellowship in St. Paul, Minnesota. And then I returned back to Nebraska and was there for several years as academic faculty, as well as an EMS fellowship director. I was lucky to serve in many roles, including the title of medical director for several agencies, that were a large mix of career department, fire departments versus some volunteer and rural agencies as well, and then served as medical director for a interfacility critical transport company, which took a lot of time but was well worth it, and served as assistant medical director for several other agencies as well. Through my work and over the years, I've developed a passion for innovation and asking the question, why and what else can we do, which has kind of led us down this avenue today. But I've been lucky enough to be involved with several individuals on some group projects, including a couple patents in the past. So happy to be a part of that, and always trying to ask the question, why and why not? Why can't we do certain things, and what are we waiting for? So as of now, I'm currently practicing emergency medicine out in Minnesota, and lucky to be the chief medical officer for Hinckley Medical, who's today's sponsor. And I'll pass it over to Mark to introduce himself.
Thanks, Dr. Campos. My name is Mark McCullough. I'm not with Hinckley Medical. I'm with the government. I'm here to help. So I actually work for the city of West Des Moines, which is south central Iowa. I'm the assistant chief of EMS operations there. I've been in EMS for over 25 years now. That puts me in the last century. I actually started like many EMS providers. I started in high school with my EMT program and went from there. I studied at South Dakota State, studied at Simpson College, and more recently at Drake University here in central Iowa on public administration. So almost half of those 26 years have been spent in quality management, QA/QI, as the training officer here in the city of West Des Moines. And that has given me a very strong passion for measuring quality and providing quality care in EMS. And now branching into administration, really using administrative means to facilitate the delivery of quality care. And I'm also developing a very strong interest, as I think you'll find later in this show, for our future and for the integration of technology. I've worked with the Iowa EMS Association for many years. I'm past president and their legislative chair. And we've recently formed a technology committee there to kind of keep keep an eye and be part of this emerging, exploding technology interface between EMS and our patients. So that's me.
Thanks, Mark. And then we'll go over disclosure. So like I said, my only disclosure is that I'm Chief Medical Officer for Hinkley Medical, is today's sponsor, but no other financial relationships. And Mark, you can.
And I'm not. I have no other financial relationships to disclose, just that I work for the municipal government.
And so today we're going to go over some learning objectives. Just anytime we do a webcast, a conversation like this, I want you to take something away from it. So we're going to be looking at the importance of weight-based dosing in EMS and review some of the pertinent literature, discuss some of the challenges of weight estimations and its impact on dosing, and then review some legal implications from recent cases that are kind of making headlines. And then, like Mark mentioned, kind of discuss some of the emerging technologies and innovative solutions moving forward. And thank you all for joining us today. So I think it was courageous for Mark and I to choose this topic as something to talk about, because in the emerging world of EMS and progressive changes we've seen the field go through over the last several years, medication dosing is not one of the sexiest titles there. We're competing with pre-hospital ultrasound, mechanically assisted CPR, pre-hospital ECMO, and most recently, whole blood transfusions in the field, which I definitely think has its place and its purpose in EMS. And I applaud those agencies and programs that are advancing the care of EMS and what we're able to do pre-hospital, things that I probably wouldn't even dream about 10, 20 years ago. But with this conversation here, for lack of a better term, I think we're kind of going to be going back to some of the basics, back to when medications first started being carried on ambulances decades ago, where medication was being delivered. And, we know now that weight-based dosing is the standard of care when it comes to EMS. And what we mean by weight-based dosing is when you're giving a medication, the formula and the formulation that you're going to be using is going to require you to give some sort of milligrams per kilogram or micrograms per kilogram. Or if you're really kind of paddling up creek, you're looking at micrograms per kilogram per minute on dosing and pumps and those things. But, I don't want to get too much into the weeds when it comes to that. But, this is the standard that's been set for several years. But there have been a few hiccups and issues when it comes to medication dosing. We know now that there are certain therapeutic ranges and therapeutic doses to give for certain medications, whether it's pain medication, whether it's medication to slow your heart rate down, whether it's medication, cardiac arrest, that each medicine has its own therapeutic dose, and delivering too much or too little can have pretty serious consequences. If you're giving fentanyl and you give too much, you could take away someone's respiratory drive and lead to respiratory suppression, which is a significant complication on its own that we know about. Or giving too little medication, say in a seizure patient, could continue to allow a patient to seize and have some very severe consequences to it. I think over the years the question is there a standard of care when it comes to dosing? And outside of weight-based dosing, I think the closest we've come to is the American Heart Association guidelines giving ACLS and for advanced cardiac life support, giving standard dosing when it comes to adults, or PALS when it comes to pediatrics. All those medications are weight-based dosing. It's one of the most important things that it does start with the weight. We're pretty good about obtaining vital signs on patients. But I think one of the struggle points that we see is obtaining an accurate weight. And Mark, you can talk a little bit more, at least just what we've discussed before is, shouldn't weight even be considered a vital sign at this point?
Yeah, I think to rewind a little bit, it's important for us to understand as an EMS profession where we're at in our history right now. It helps us. It really kind of grounds us and helps us move forward if we know where we're at. And I think it's important to realize that we are emerging from our formative years. And I'm sure I wasn't around for it 400 years ago, but the fire service went through similar things. What are we? Are we public safety? Are we medicine? Are we communications? Are we transportation, which is where we've landed? And I think the true answer is we are an amalgamation of all those things. We are our own entity, our own thing. EMS is EMS. But when we practice medicine, we have to pull ourselves up to that standard. And that is obtaining accurate measurements. We take measurements in so many different places. As Dr. Campos pointed out, we take a blood pressure. We do that by a prescribed measure. That is, it is the same every time. And we teach that regular method. When we measure a heart rate, we do that the same way every time. When we measure peripheral pulses, when we obtain a 12 lead, we do that in a repeatable way every time. And that is raising ourselves up to the standard of medicine. And we do that in other fields. When we talk about the transportation of our patients, we rise up to transportation standards. We belt our patients. We secure things in our ambulance to provide the safest mode of transportation. We conform to the regular communications guidelines when it comes to radio communications. So this aspect of EMS, this medical aspect of EMS, we need to pull ourselves up to the medical professions. And part of that is administering patient safe and therapeutic medications if we choose to do that.
Yeah, and I definitely agree with Mark. And one of the biggest issues we find with weight-based dosing is that first part is how do we accurately get a weight? I over the past several years, I'll run into individuals at national conferences and ask, how they dose their medications. And the answer is almost universally weight-based dosing. And I follow up with, how do you obtain your weights? And then there is a whole constellation of answers, but most of them end up being, well, we guess. Well, we're pretty good at it. I've been doing this for a long time, and we'll go over some literature here that kind of makes us scratch our heads a little bit. But the most important step is trying to obtain an accurate weight, and the means to do that is always depends on the patient, on the environment, on the call that you're on. Where if we're following weight-based dosing, there's a big risk if you don't start with that first accurate weight. And we know that can lead to potential dosing errors, underdosing, overdosing, and most importantly, when that comes to pediatric patients as well. I think we've gotten comfortable in adult patients and EMS where standard doses can be of benefit. I said, trust me, I know it's a lot easier to memorize whole numbers, and it's goes by 50s, 20, 25, 100 than it is to do fractions of an amount. But sometimes this can lead to patients who are bigger in size, smaller in size, not receiving the proper dosing that they should. And I think there is a call for improved practice and enhancing dosing accuracy. And part of that does come back to, getting an accurate weight. There have been several advancements over the years that help us kind of chip away at this problem. There's been different formulas that have been used. There's been length-based tapes that have been provided, which has helped with the estimation methods. And then ideal body weight has been one in the last 10 years that has been used as well. And it's interesting as I've become passionate about weight-based dosing, doing the literature, finding out that ideal body weight actually was started by insurance companies in the early 1900s, where they used ideal body weight to try to calculate people's mortalities based off their size. And that's the best way they decided whether or not they'd insure somebody with life insurance is if what their ideal body weight was, kind of correlate that to their mortality and expected life expectancy, which is interesting. It was never meant for to be used as a weight to dose medications, but here we are. With these length-based tapes, there's been a few iterations and a few updates to these tapes as well that have shown some improvements, because I think we'll see in a little bit here that there's a hierarchy of how we can obtain a weight, and guessing, unfortunately, tends to be near the bottom as the way to do it. But somehow that ends up being how a lot of times that's the only tools we're left with. If you go into any hospital clinic these days, myself working in the emergency department, one of the things I want first on a pediatric patient is a weight, because that's so important. And obtaining that weight lets you know what you're going to be dosing, even something as simple as a fever, and giving something like acetaminophen. It's you want to dose, otherwise you don't want me guessing how much your young child is is going to weigh. And when it comes to EMS, the problem we run into is, I think around the country, about 10 to 15% of calls are pediatric calls. Every medication we give is weight-based in pediatrics. Now, if we're having to give medications to a pediatric patient, they're probably pretty sick. And so we typically run into what I refer to as these halo cases, or high acuity, low occurrence. These are the cases where what you do in those moments and the medications we're giving are going to make a significant impact, whether it's a seizure, whether it's cardiac arrest, or whether it's something involving RSI. These are the patients where they need the most attention to detail and the most accurate dosing. And we know that in the field, there's trouble having to do that. And Mark, you can kind of expand on that, the issues we have with your experience with weight estimations in the field.
Yeah, it's always sort of been at least here in my sphere here in Iowa, it's always sort of been during training sessions, especially, always kind of a joke. Well, oh yeah, they're 220 pounds. And I actually am, but that's just, a guess in medicine is unacceptable. You have to think about the weight of what we're doing. We're literally, someone's trusting us to inject a chemical substance into their body, and you better be deliberate about that. You better be right about that. That's a huge responsibility, and that's a huge amount of trust that our patients put in us when they call 911. Our patients get to choose who prepares their food, and they even get to choose their doctors. If you go to a doctor, you don't like them, you go to the other one. But they have no choice who shows up at their door when they call 911. So they rely on the industry. They rely on us to ensure that our providers are providing them safe care, and they're competent in doing so. So I would just caution people with that guess. I don't think that's appropriate. I think we can do better than that as a profession. And if we want to consider ourselves medical professionals, or at least a big portion of our job, we do, again, need to rise up to those standards. So there's my soapbox on that, I guess you could say. I think we can do better, and that's the whole point of quality assurance. A very important feature of a EMS agency is their quality assurance program, and there are certain things that we're just really bad at, and our job is to identify those and work out ways, investigate ways that we can improve those processes. And if weight guessing is one of those things, let's figure out a way, whether it be, a tape, asking, get it into the medic's routine practice to ask weight, or, work on better ways to actually measure that metric. So.
No, and you raise valid points, Mark. And I, not to nerd out, but I always think it's important to look at the literature when it comes back to this topic. And there are dozens and dozens of articles out there that kind of emphasize what we've been discussing. And I'm just going to point a spotlight on a couple of them. And one of the ones I'll talk about here is by Dr. John Hoyle out in Western Michigan, where this was from 2017, published in the Pre-Hospital Emergency Care Journal, where they gave a national survey out to about 1,000 paramedics discussing pediatric pre-hospital care and dosing errors. And they found that about 45% of these paramedics had been personally familiar with a case where EMS delivered an incorrect pediatric dose. This was one that it's kind of shocking to know that number, how high that is. And that's just being aware of it or being familiar with the case. And of these respondents as well, I think it was about 60% said they felt like their training, their initial paramedic training program did not include enough pediatric training, which is something something we've seen time and time again about training, and express the importance of training, where, you know, a lot of people go through their initial training process, and that gives you the foundation, but it's an ongoing process to continue your education. You know, that's why, you know, there's CEUs, there's the goal is to advance the care and build upon the foundation that you start with at your initial programs. You know, and we think that delivering medications to pediatric patients is not that common an event. However, 2/3 of the respondents here said they've done it within the last year. So it's definitely something that is occurring, and we want people to feel comfortable that they're doing that. You know, another, again, by Dr. John Hoyle, who's focused a lot on pediatric research, and that's why I really appreciate his research that he's done. You know, one of the changes they did was create a pediatric drug dosing reference for the state, and once they had that dosing reference available to the medics, they put them through 142 simulation cases, including cardiac arrest and seizures. Even after providing these drug references, they found that about a third of the epinephrine doses in their cardiac arrest simulations were incorrect. And up to 8% of those were tenfold in overdose, which is significant when it comes to cardiac arrest, right? And these are the most critical patients that you have. So it's something we need to really be paying attention to. And then just a quick reference, when they looked at the seizure scenarios, only about 56% of the benzodiazepine doses were correct. So again, even with the tools given to us, there's a concern that even at that point, you know, we need to be focusing on, you know, not just the reference there, but also the training that could help improve what we're doing with our pediatric patients. You know, in describing some of the tools that, you know, Dr. Wells performed a systematic review and meta-analysis on using one of the length-based tapes. That is an estimation tool that I've used in the past that is very present in not only pre-hospital, but also hospitals. This is published in Resuscitation in 2017 that looked at weight estimation accuracy, and they found that it was suboptimal in many populations, and that just over 50% of these patients or children received an estimation that was within 10% of their actual weight. Having dove into this literature, it's interesting to know that, you know, weight estimation accuracy when it comes to pediatric dosing is considered accurate within 10 to 20%. You know, thinking 100-pound individual, that's 20 pounds either way. A 40-pound swing is what we still consider accurate because of our lack of tools to be able to find accurate measurements. You know, and one of the things they found in the study too was there was a high rate of incorrect usage of the tape itself, which again points back to training. You know, I think if we hadn't hit it enough already, I think training, say it 3 times in a row, is very, very important when we have the tools to train those individuals correctly on those tools. And then just to review back on, you know, round back on weight estimation in general. So I've been doing this for over a decade, emergency medicine, and we see pediatric patients and they still make me nervous. You know, just, I think anyone who says that they don't is lying. But I see pediatric patients almost every shift I have in the emergency department, and I would like to think that I'm good at guessing weights, especially adults at this point. But I know that that's not true. Even on the hospital stretchers we have to obtain a weight, I know it's not true because I'll always be off a little bit if I'm trying to guess before we obtain that weight. But this study here was a systematic review. It looked at 80 different studies to try to find the best estimation methods in children. And I don't know if I'm surprised or not, but the most accurate method was asking the parents, what the parents knew. And it's funny, if you ask my wife, she'll know how much each of my kids weigh. I don't. And, you know, she's the one who's taken them to their doctor's appointment. So I'd like to think that's why. But she's fairly accurate when it comes to that. You know, so it's like, and followed by that are the length-based models or estimated tapes, or what kind of takes second place. And it's actually healthcare workers are very inaccurate. The studies that they referenced talked about nurses and physicians, but we know now that guessing is almost a bad word now, that we shouldn't be using that. You know, it's like Mark mentioned before, guessing is something we need to be getting away from.
Yeah, it's just unacceptable. Think about the placement of an endotracheal tube. If the paramedic didn't have a great view. They couldn't see the cords or the arytenoid cartilage. And they said, well, I advanced the tube because I guessed that that's where the glottic opening was. That's unacceptable. Now, that's an extreme example, but one thing Dr. Campos mentioned, the most accurate measure there was asking the parents. And that makes me think quite a bit about this family-centered care that's becoming so important for our EMS agencies to be considerate of. And I can't think of a better icebreaker or a better way to start involving parents in their child's care than to ask them, "Hey, what's baby's weight?" It's very helpful for us, and can you participate in their care? And what a great way to break the ice and ask them a question that they usually know.
Yeah. Yeah, no, and it's, and we're discussing the process of obtaining a weight, and if only it were that easy, right? If we just have a weight, but we know in EMS, weight-based dosing, it's more than that. And I think being on the hospital or emergency department side of things is you have people who play certain roles where, as a physician, you get a history, you do a physical exam, you're able to diagnose and put in orders, right? And then the nurses look at your orders, verify, draw up the medication, someone else is obtaining the weight. There's a very large process that goes into it, and you're scanning into the EMR and doing a lot of things and stopgaps. However, in EMS, you're doing all of that. And it's 1 a.m. and you're on your it's you, if you have another medic with you and an EMT, it puts you in a position that does not benefit you. There's a multi-step process to giving a medication, and we'll focus on peds here, where say it's 1 a.m. you've been woken up, you're on the way to a call of unresponsive child, you show up to scene and child seizing. So now you're trying to figure out, assuming the scene is going to be chaos, because it always is, right? You have family members there. Hopefully you're there with a large crew. If not, maybe just two of you that are there, but you're trying to navigate the scene, evaluate your patient. And now, say your parents are on top of things and can give you a weight right away. Best case scenario, you're like, yep, saw a doctor today. Here's their paperwork. They weigh 25 pounds, right? So now you're having, because especially in the US, we don't follow the metric system. You're having to convert 25 pounds times 2.2. You're doing calculation right there, step one. So now you know your weight. Now you're having to determine the medication you want and do that calculation again, right? So you're doing milligrams per kilogram. That's step two. Now, three, you're grabbing the vial of medication that you need, and you're having to look at the concentration. And again, we're doing math again, trying to figure out how much you need. Again, it's 1 a.m. Parents are screaming, kid is seizing. If you're not stressed by this, you must be an expert in the field, because the thought of that just gives me palpitations. So it's a multi-step process, and then drawing up the med and giving the med. It's a high-stress environment, and unfortunately, I feel that the system is set up to allow people to fail because it is such a high-risk, high error-prone environment that even training in a classroom setting will not set you up for in-the-moment decisions like this. So it's very, very difficult, even with adult standard doses in a high acuity environment like that. It can be very difficult, and that lets us have to focus on what are some of the best practices. And Mark, with your experience in QA, I think you have a lot to say on this, so jump on in.
I do. Yeah, I do. I also get palpitations just hearing about that type of call. And I think from a QA perspective, it's often grouped with education for a reason. This is a training. This has a huge training component, but also from the QA perspective, identifying system controls for reducing errors or minimizing risk is really important. And that sounds like some academic talk, but let me tell you what that entails. And I'll just give you an example. It was it's kind of a Murphy's Law example. And that is, shortly after becoming a brand new training officer, I had a little bit of administrative pull, and we were carrying, at the time, we had 3 different benzodiazepines on our ambulances, and we carried Versed, Valium, and Ativan. And about every quarter, we'd have a big debate on how long Ativan should be refrigerated or not. And then we used Valium for one very specific thing, muscle spasms and a isolated musculoskeletal injury. And I kind of assessed the situation and assessed the usage of all these benzodiazepines, as well as the administrative burden of keeping and monitoring controlled substances on the ambulance. And I came to the conclusion that we only really need Versed. It's water soluble. It can be atomized. It can be administered by intramuscular injection. It's effective. It's quick. Great. Well, shortly after that happened, this medication now has, of course, plagued me after making that decision, and it became our most commonly errored medication, and that was very troubling. We don't make a lot of medication errors, and for us to make several in the course of a year's time is a big deal that I spend a lot of effort on. And really, in examining those medication errors, it was absolutely vital for us administratively as a crew to keep track of those incidents. So this is where the idea of just culture and incident reporting comes in as just an absolutely vital control for an EMS agency in providing safe patient care. We have to have an atypical patient care reporting process. We have to have an administrative way to keep track of those changes and then, review those for continual change and improvement. So through our incident reporting process, atypical patient care reporting process, we identified several features of this benzodiazepine medication error. And that was that it's administered for 3 very high stress situations. It's administered for behavioral incidents. It's administered for seizures, and then it's administered for post-intubation sedation. This is not our current practice, but back when this surfaced as a problem. All 3 of those, just like Dr. Campos was just talking about, very high stress situations. On top of that, we recognize that each of those afflictions, each of those protocols called for a different dose. So for sedation, we were giving 1 to 2.5, or as a behavioral dose. For sedation, we're giving 2.5 to 5. And for seizures, we might be given a weight-based 0.1 milligram per kilogram to a max of 4. And our paramedics were either confusing those protocols or, administering one protocol to a different type of situation. So that was the first system control issue that we identified through that reporting process. That's a standard QA approach. The second thing that we identified was that it comes in a very unusual concentration. It's concentrated 5 milligrams per milliliter, which makes math really difficult. So what we were tasked with, and this is something that I think when you talk about quality assurance, it's important to get your crew members involved to make it their solution, not just the QA guy, the chief on high. I think it's really important and crew members, in my experience, have been absolutely willing to get their feet wet and work towards improving the service that they provide. So it's a great way to get people involved and to give them a taste of administration and management. So we got involved, and really what we came to was we need to regulate the dosing schedule so that it's the same or as close as possible to the same for each of these uses. And if it can't be done, then maybe we look at a different type of medication. Another couple of changes, obviously, it's hit quarterly in training, and really just beat into people, so it's almost a muscle memory with your problematic medication doses. So you really have to take a look at a systems approach and try to figure out what the root cause is for any type of medication error. If it's a weight estimation, address it. If it's something like confusion in your protocols, address it. So there's the QA tidbit.
I'd reemphasize what Mark is saying. It's like if you don't have a QA process in your current agency, ask that question. Why not? Because you'd be surprised at things that start to pop up and show up just from a simple review process. And there are QA standards out there. I'll give a shout out to NEMSCOR, the National EMS Quality Alliance. They have measures put out there that you could start as just basic QA process. It's very, very important to have one. And as I said, the foundation is there. Just applying it to your system, it will be a victory in itself. And or just to start something small, even looking at EKG times or medication administration, on-scene times, something low-hanging fruit is a great place to start.
One of the most significant pieces of advice I've received in my entire career came from one of our CAS accreditors. It was my first year as a QA guy, and that's a hard accreditation, but it was so valuable, and it was basically start small and ask a question, answer it with data, and then address the issue with quality improvement initiatives, training, changes to protocol, and then remeasure it. Quality improvement oftentimes gets too grand. We look at all of these measures, we measure all sorts of data, and it doesn't necessarily provide value so that I go to my medical director and say, Dr. Torstensen, we were 95% accurate in our fentanyl dosing or in our solumedrol dosing to pediatric patients. You really get that specific and take a look at each point rather than measuring all of your medication doses all at once, because you can quickly become overwhelmed.
Yeah, no, and I promised to wheel Mark in if we start going down the QA route, because we're not going to keep it.
Thank you.
QA, but we can get lost for hours on that. So rounding back with just the weight-based dosing that we talked about, so we know that there's issues with estimating weights, and we know that the process of drawing up a medication, doing the right calculations to get there is very stressful. If that hasn't made anyone worried, I'm also be worried as well in this situation. But unfortunately, we know that this does have some consequences. And just to highlight some of these cases, I don't think anyone in EMS does not know the name Elijah McClain. Very unfortunate incident that happened back in 2019. I'm going to do maybe like a 5,000-foot view on this case, not 10,000, but not in depth, because I'm not a lawyer, and I'll preface with saying that, not a lawyer at all. But some of the issues that were brought up in this specific case revolve around medication dosing. Now, Elijah McClain did receive a dose of ketamine. At that time was 500 milligrams, which, going in line with their protocols, some of the paramedics who unfortunately were criminally charged in this case were put on the stand, have to answer why they dosed a certain medication at that dose. Listening, their defense attorneys have come out and discussed some of the issues with that they've mentioned with the dosing, and part of it was the training, that they were told that they had standard block dosing, that they could give 300, 400, 500, as long as you're in the ballpark, that's okay. And one of the issues that came out of this was a weight estimation. They had to answer on the stand was, why did you give this dose? And because they believe the patient was about 100 kilograms or 220 pounds, when it turns out he's actually 140 kilograms, or around 65 kilograms, 140 pounds or 65 kilograms. So that came into the spotlight, whether we wanted to or not. We need to realize that the actions that we perform, the medications that we give, do have consequences. And unfortunately, that led to a respiratory and cardiac arrest in that situation. And I think, we've seen it kind of play out on the national spotlight here. But this, again, focuses, switches are, what we do in EMS and emergency medicine is we're trying to help people. We need to know that. Now, people who are blatantly and being negligent on certain things obviously need to be held accountable. But when we're taking care of these critical patients, the estimating just doesn't cut it anymore. We need to be making sure that what we're doing is in our patient's best interest, and using the tools we have given to us or provided to us. And if we don't have those, that we need to be finding those. There's some other cases as well at a national conference this year. every year, medical directors conference, they discuss, what are the big issues we're seeing in liability? And 3 of the cases that were brought up had to do with medication dosing errors. One was the wrong medication was given. Another one, vial ketamine was drawn up, and they were supposed to give just a pain dose, which is usually under 30 milligrams, and ended up giving the entire syringe, which was 500 milligrams, which is currently in family is filing a lawsuit against the EMS providers there because of that. And I think that does shed light on what Mark had said earlier about creating a just culture, because in some of these instances, the later ones I'd mentioned, that there was claims that the providers tried to cover that up, that they tried to not report the errors right away, which is a concern and an issue all on its own. We need to make sure that we're establishing a culture where if an error occurs, that it needs, and it's recognized, it needs to be reported right away and try to remediate the error best way we can. And we've seen now, especially in Colorado, has kind of led the charge where, my personal belief and my personal opinion is that healthcare and medical decisions should be left to medical providers, people who are trained in taking care of a patient. The indications, contraindications, dosing should be left to those who are trained to do so. We've seen issues where lawmakers are starting to dictate medical care, which creates an issue in its own, and we can get into that. But I'll kind of leave it at that. Where the landscape is changing, and unfortunately, it's gone now where the medications we give, the dosing that we do, we're going to be held accountable for that, whether we want to or not. We know that the landscape is changing. That's something that we need to be adapting our practices to make sure that we're meeting standards that are there. Was it a few years ago where a nursing came out with the 5 R's, the 5 rights: the right patient, right medication, right time, right dose, and right route. And to add the 2 other rights onto there, we need to be looking at the right response and the right documentation. Again, in these cases, the thing that's been brought up again is a reaction to the medication wasn't recognized. There was a delay in recognition, and the documentation wasn't there to support it. And I think anyone who's going to be drawing up a medication, push it through an IV. It's so important that we recognize there's an intended response, whether it's fentanyl for pain, whether it's ketamine for sedation. We need to know the consequences and how to deal with any poor side effect of the medication. It's always been my belief where if you can give a medication or do a procedure, you need to know how to deal with the consequences or one of the risks of it. If you put in a central line as a physician, you're expected how to deal with bleeding or a potential pneumothorax. If you're doing it, you need to be able to know the consequences down the road or risks that a patient has. And I think that also applies to medication, and then documenting appropriately. I have to document for every patient encounter I do, and it's a headache and it's the worst thing ever, but it's so important. I remember in my training, I was told there's only 2 people who end up reading your chart at the end of the day. It's going to be another physician who's taking care of the patient, or another medical provider who's taking care of the patient, or lawyers, right? Those are the 2 people who read charts. That stuck with me forever, where it's like, document why you did something, why you're doing something, or what you were doing is so important to be doing. Then, as when it comes to documentation and how we advance care, we really need to look at putting the right tools in the hands of our providers. We've seen just in the last decade now, we've gone from the load and go times to the stay and play. And now we're bringing CT scanners out of the ER and into the hospital and into the streets. We're seeing mobile stroke units, mobile ECMO teams, ultrasound being used on patients pre-hospital care. We're advancing the technologies that are available to us. And not only that, we're real-time data integration. We're having, with the advancements in telemedicine and tele-EMS, you can speak to a neurologist, over a FaceTime, evaluate a patient, and decide whether or not to give thrombolytics, which again is another weight-based medication. So there are several instances where we're pulling this technology out of the hospital, yet we're still lacking in certain areas. And the goal should be to remove these burdens, these estimations on our pre-hospital providers in these very stressful situations. Obviously Hinkley Medical is our sponsor today, and I'll touch base. This is something I'm passionate about. Up until now, there hasn't been a product to weigh a patient, and that's been an issue that's was voiced in some of these court cases I mentioned earlier. It's like there's no way to weigh a patient, and Hinkley Medical now has patented technology where they have the ability to weigh a patient on a stretcher. OneWeight is the scale that fixes the stretchers, and you can weigh a patient, complemented by OneDose, which is software that you have your protocols, your dosing on there to be able to accurately dose a patient and do those calculations right then and there at literally in the hands of your app, your device, your computer, whatever you have. That those options are there, and I think those technology advancements are what's the answer to the methodology that we haven't had an answer for. It's when you can fax in 12 lead EKG to a hospital before a patient arrives who has a STEMI, yet we're still guessing weights becomes a big problem. And I think Mark, you have a lot more to say on the future of EMS and technology, so I'll hand it over to you.
Yeah, we're close to the top, so you might have to pull me back like you do with QA. I'm passionate about these things, but I think we again we're seeing the integration of real-time data, and we have to be ready. First of all, we have to be ready to change, and some of that's going to be mopping up our ego. I think about some of the other changes that we've gone through in EMS over the years, and one really easy, benign thing to talk about is fluid administration to trauma patients. Back late 90s, early 2000s, I was judged on my capability of pumping as many liters of fluid into a trauma patient as I could. And then right around the kind of the turn of the century, I can't even believe I'm saying that, but right around those early 2000s, we adopted this idea of permissive hypotension. And it turns out that data driven, that is what makes a difference in trauma patients, and that we have to be ready for some of these data-driven decisions. There's not a lot of data use yet in EMS, but we're right on the cusp of an explosion. We have to be ready for some of those answers to tell us that we've been wrong for all these years. And some of these decisions are going to be beyond patient care. These are in staffing decisions. There's pretty strong evidence that supports the idea that working greater than 16-hour shifts puts our providers at a significantly higher risk of injury. We talk about watching people's unit hour utilization for fatigue and pulling people off the streets. Those are things that are going to complicate our organizations, but ultimately they're better for our employees. They're better for the people they serve. And we may end up through the use of data, through the use of documenting errors or documenting poor outcomes, and we find that really in your 23rd hour of wakefulness, you probably shouldn't be administering medications alone in the back of an ambulance. And we have to be ready to admit we were wrong and make changes to improve our practice in the future. I'm also very excited for real-time use of data. Think about the augmentation of decision making for our EMS providers. Right now we have a very young profession. Turnovers estimated in some regions as high as 30% per year. And that gives us a lot of inexperienced providers on the street. And if we can assist them in making, clinical impressions and making differential diagnoses with active use of technology. Think about, the example, a younger paramedic recognizes a patient with some abdominal pain, and they kind of work the patient up, and maybe they administer some fentanyl, or they transport the patient, and an experienced provider sees the same patient and they recognize, oh, you know what, this guy's a little bit taller. He kind of has this concave chest, and I've seen this before. And he's a smoker and he has hypertension. And I think, oh man, what does that pain feel like? And then he might use the word tearing or ripping to describe it. And we all know where that's going, right? That's a AAA. If we have a device that's listening to we're inputting data, we start collecting data on someone as soon as they call 911. We can use that data in real time. And I could go on for an hour on that. So I'll stop, but think about that use of that integration of real-time data in your services. I just want to kind of point out a book. I recently read a book. There's a book by Donnie Woodyard out there. It's about AI, the future of EMS, and artificial intelligence and technology. Phenomenal read. Really gets you thinking about our future. I would just highly recommend that. Great, great read.
Yeah, no, it's exciting to see where we'll be 5 to 10 years from now. The advances that we'll do. AI is a scary thing until until you know how to use it for good.
Yep.
But yeah, it's definitely going to have its place in EMS. Whether we welcome it with open arms or not, we know that it's part of the future.
And here's another training need. Obviously we'll have to train our employees to use and integrate with technology. That'll be another huge training change in our future.
Oh yeah. And we're kind of getting near the top of the hour here, so we'll kind of wrap up. And there are some takeaway points. Like we mentioned before, it's a weight estimation is what it is. We're estimating weights. It's better. Estimating is better than guessing, and getting the right tools in your hands to do a better job of that. And people who are here listening, if you're in the trenches, you're taking care of the patients, push it up that ladder. You have to make sure that the people looking out for you, myself as a medical director, I need to make sure that my crews have the right tools to do the best they can for their patients. To show up to scene and have to guess how much a 3-year-old weighs, it's like, we just can't be doing that. Whether it's a reference card, whether it's an app, software, whether you have a scale on a stretcher, those are all tools you need to be able to take care of your patients in their most critical times. So push it up the chain. Talk to your medical directors about this. This is not something new. It's not. Peds have always been peds, adults have been adults, and weights have always been weights. Is how we dose medication is something we've done. We just need to continue to do a better job of it and have that system in place to improve that. And just rounding back, we know weight-based dosing is critical, especially when it comes to those young patients, and trying to eliminate the cognitive errors that can happen in that multi-step process. It should be a goal and something you can look at for your system. And again, not to scare anyone, but we know that these legal cases, as a medical director, my biggest fear is one day that someone's going to know the name of our small town, the name of our EMS agency is going to be all over headlines. That's my biggest fear. And so you do the best you can to set your crews up for success so that, we do the best we can, the tools that we have, the knowledge we have, and the patients that we're taking care of. And I think that is the biggest takeaway from this is we have a responsibility to our patients to do the best that we can, to give them the best chance of whatever they're going through. Whether that's improving training, whether that's adopting technology, the goal should be to ensure patient safety. Because like Mark, you mentioned earlier, they don't get a choice. When they call 911, we come to take care of them. And that, that should prepare us, if anything, and motivate us to do the best that we can for them.
I think so much about those high risk populations, those fragile populations. Think about a chronic respiratory child. This maybe a 6 or 8-year-old with a chronic respiratory event. They use their entire metabolism on breathing, and they're underweight. And then we come along and we overdose them. That to me is a scary thing that I think we need to do better about. And just, again, be careful and be safe, and provide the best care we can. It's our obligation.
Yeah, no, I couldn't put it any better. And so we'll wrap up here, and we do have our contact information here for myself, to email, and Mark as well. Any questions, comments, concerns? I think we do have a little bit of QA session. I'll throw it back to Jeff here, but thank you everyone for your time and listening, and hopefully you've taken some information away from this to be beneficial. If anything, just turn the wheels a little bit. to get the process going is ask the questions. Don't forget the why and the why nots, because those are important. Be the squeaky wheel.
Yeah, well put. Thanks both of you for this presentation. It was very informative, and I learned a lot, and I'm sure our audience did too. So folks, if you have any questions for the presenters today, feel free to drop them in the Q&A box. While we're waiting for that, I'll kick us off with a question that I have. Are there any other specific patient populations, geriatric, obese maybe, where weight accuracy is even more critical? And what are their concerns?
Yeah, no, I think that's a very valid question. And some of the things that we do struggle with, in our country in general, it's these special populations with geriatrics, thin, frail, are going to respond very differently to medications compared to a healthy 40-something-year-old, who broke their leg or at the gym running. You give a certain dose of fentanyl and you give the same dose to someone who's similar weight but elderly, can respond very different to medication. And I think that's where we focus on the last two R's. Is it the right response? To know that just because you gave fentanyl is not a time to sit back. It's to keep on the monitor, just watch their pulse ox, look at their respiratory drive, look at their mentation. Luckily we have a medication that can reverse that, Narcan. It's like if it's not the right response, we can undo that one, which is
that end title. Use that end title. That is the golden standard.
Yeah, no, and I agree. It's the few more seconds it takes to set up an end title. I'm a huge fan of end title, and I won't go on a tangent about it, but end title, especially in ketamine's not a bad word. I'll say that ketamine is not a bad word. But when giving ketamine, an end title should almost be considered the standard of care. End title, pulse ox, cardiac monitor. Anytime you give end title, as soon as it's safe to do so, especially if you're giving it for agitation.
Yep.
Yeah. No, it's a very, very good question.
Right. All right. We got a few coming in now. Do you have any evidence-based approaches to estimate a patient weight that are obviously obese? And are you aware of any research using BMI based on skin fold testing? That comes from Chris in the audience.
That's a good question. Thank you for the question, Chris. BMI research on skin fold testing. I'm not familiar with any of that skin fold testing. As I send that my way, I'd be interested to to learn about that. No, I have not seen that. I know there are certain BMI calculators based off circumference of thighs, upper arms, as well. I think with obese patients, there's been focus on certain reduction in dosing. And I think that's where ideal body weight can play a role as well, where we know that with certain lipophilic medications that are going to be absorbed by fatty tissues can have detrimental responses. When we run into big issues like that, I always typically think of people who are in the ICU on a Versed drip for some reason, which absorbs in the adipose tissue of the body. That's going to hang around for a long time and take a long time to get away. That's when we really need to be focused on ideal body weights, because that's when we try to minimize the long-term effects of a certain medication while also being able to get that therapeutic sedation on board as well. Mark, do you know about any of the skin fold testing? I'm not aware of that.
Yeah, I'm thinking maybe they're talking about the caliper testing of adipose tissue with again, just helps. I think there's likely an equation out there with the caliper test versus the patient's height. So you can probably calculate their BMI versus their height to come up with a weight. I'm sure that there's a calculation out there that allows for that, or gives the provider a good idea of how heavy they are. I saw another question about, well, what if the patient is unable to be placed on a scale? And again, that happens. I think you have to get this into the standard practice of the paramedics to ask the weight question, or practice with patients of known weight. So when we have patients every day that do fit on a scale, or that you can apply a height-based measure to, or you can ask their parents, every piece of input that you receive as a paramedic makes you better for the future. So when you start to see a patient and then know their weight and maybe know about how tall they are, that will help you make a more accurate assessment in the future, than just literally just kind of guessing blindly and hoping that you're right. So I think this weight estimation can be learned and improved, though still not as good as an actual weight, asking the patient, or using a length-based tape.
Mhm.
If you were like a few in the audience are asking about any peer-reviewed research on this, not now, but can you maybe forward us information later and we'll send it out to the audience later on?
Yeah, is it in terms of when say solution, are they referring to the one way the stretcher scale?
Yeah, scale.
That yeah, so it's a newer product, so peer-reviewed research is something we're aiming to do. I know we've done internal QI research in itself that shows accuracy. I think a question that I've seen as well, and which we've had before, which as a medical director myself, it's like, well, what do you do if you can't get the patient to the stretcher? And it's like, that's a very valid question, because a lot of times you can't get them to the stretcher or you're initiating care on scene. I mean, we work cardiac arrest on scene. And if you can't get the stretcher in easily or put them on there, you have to use the tools that you have. And sometimes your length-based tapes when it comes to pediatrics or your other estimation tools are a good solution to just guessing being the alternative. So I encourage people to use the tools that they have. And there are age-based formulas as well when it comes to pediatrics that a lot of software like our OneDose uses as well. Just if you don't have that option, you may have to do the best method, which is going to be estimating until you're able to get a weight and hopefully transport the patients, get those accurate weights.
Great. And this will be the last question because I want to be conscious of everyone's time. And it's more of a general question because, how do you deal with a salty paramedic? That's what they're asking. There are some of the ways. Any tips on getting them to,
Mark, I'm gonna let
try
you
other
answer
things?
Yeah,
that.
absolutely. I'll put the administrative hat on here. A lot. Boy, that's a sensitive situation. Sometimes informal leaders can be your biggest opposition, right? Because you can provide all the evidence in the world, and if your informal leadership, who are your crew members, who everybody likes and listens to, if they're not on board, then they can really crush, uh, they can really crush your hopes and dreams, right? But I think in this case, paramedics should all understand that we operate on a medical director based system, and ultimately our medical director is responsible for our care, and that's why the chain of command is so important. So even if, again, you'll always hear in interviews, well, tell us about a time that you had to follow a policy that you disagreed with. And that might be the answer to a salty old paramedic who's been around and doesn't want to see change. Because ultimately, this is an easy one. This comes down to providing the safest, the um, most medically congruent or in line with current practice type of medicine that we can provide. It's hard to argue against that. I mean, you kind of look like the fool if you're the one that says, no, I don't want to do the best job.
Yep, well put. All right. Well, with that, I want to say thank you to today's presenters, Dr. Campos and Mark McCulloch. Thanks so much for your time today. And thank you again to all. Yeah, I see the applause is coming in. Yes, keep doing that. I love that in the in chat function. A lot of them. Wow, it's great. So you definitely hit something on the head with this today. It shows with the thumbs up, claps, heart emojis. So um, thank you again to Hinckley Medical for sponsoring this event. This talk will be archived on jems.com/webcasts within about a day or so. So you can share with your colleagues. And also, as when we wrap up today, you'll see a brief survey on your screen. Please take it. It helps us find out what you want to see next from us. So your input is always valued. So until we meet again, everyone, stay safe and be well. Thanks so much.
Thank you, everyone. Take care.